Welcome to today's IPFCC webinar, Advancing the Practice of Patient and Family-Centered Care Across the Health System, the Imperative of Leadership at Every Level. My name is Annette Lee. I'm delighted to serve today as your webinar host. Marie Abraham will be moderating today's webinar, and Ishma Patel will be helping with any technical assistance. To ensure an optimal experience, all lines are muted during the presentation. So we are using a new platform for anyone that has joined us from previous webinars. This platform has two options to connect with us. The first one is the Q&A feature, and that is where you would enter any questions you have for the presenter. At the end of the presentation, we'll leave a little time for the question and answer session where we can get to any of the questions that you asked during the presentation and answer them then. Any comments or technical questions you have, you can use through the chat feature, which, as I explained, is also either at the top or bottom menu bar, or if you click the three dots that say more, it should be there as well. For technical support during the webinar, Ushma will be on chat, so if you have any questions, you can ask her there, or if you have any trouble hearing or getting connected at all, you can contact us at our IPFCC phone number or her email. And now I'll turn it over to Marie.
Thanks, Annette, and thank you everyone for joining us today. We have a lot of people, and I see we still have some people coming into the webinar, and it's always great to see this kind of participation. I saw from the poll, and thank you for those of you who were able to complete the poll, that not surprising, but we do have a number of leaders joining us. We also have clinicians and staff and patient experience personnel. And we also have a good representation from patient and family advisors. So it's always nice to know who's in the room for our webinars. So I will be moderating today's webinar, and Susan's planned a great presentation today. So as Annette said, if you do have a question for Susan, you can feel free to chat that into the Q&A, that option, and I will make sure that Susan responds to that at the end of her presentation. So for any of you who are not familiar with the Institute for Patient and Family Centered Care, I just want to say a little bit about us. We were founded in 1992. We are a nonprofit organization, and our mission is to provide leadership for advancing patient and family-centered care in all healthcare settings. So we do provide on-site and off-site consulting and training. We also offer publications and videos, other resources, and educational programs such as today's webinar. You can visit our website to learn more about us and to see what resources we offer. So if you can go to the next slide, I'd like to introduce Susan Grant to all of you. Susan is the Executive Vice President and Chief Nursing Officer of Beaumont Health. She joined Beaumont in 2015 to oversee nursing practice for the 10,000 nurses throughout the system. She's the executive sponsor for advancing the practice of patient and family-centered care across the Beaumont Health System. Susan has held executive nursing positions at 3 other organizations: Emory Healthcare in Atlanta, University of Washington Medical Center in Seattle, and the Dana-Farber Cancer Institute in Boston, where she served in a leadership role for patient and family-centered transformational changes in organizational culture. We've known Susan for a very long time, and we're so pleased to have her presenting today. And with that, I will turn it over to Susan.
Great, thank you, Marie. Appreciate that. And good afternoon, everybody. Thank you for the opportunity for sharing this presentation with you today. I'm going to try to talk for about 45 minutes, 50 minutes at most, so that we do have some time for questions and answers and anything that you may want to talk about. So with that, Annette, if you can advance to the first slide, the next one, be great. Okay, So before I get started about Beaumont Health's journey with patient and family-centered care, I want to just share with you a little bit about my own journey and where my passion for patient and family-centered care comes from and why it's important to me. You have two pictures that you can see on the screen. The one on the left is Betsy Lehman, who was a patient on a unit that I was nurse manager on at Dana-Farber, and the picture on the right is my daughter, my 18-year-old daughter, Hannah. And both of those individuals have had an enormous influence on me and why I'm so passionate about patient and family-centered care. Betsy Lehman, as I said, was a patient on my unit at Dana-Farber, and Betsy had come to Dana-Farber to be treated on an investigational protocol for high-dose chemotherapy and followed by a bone marrow transplant for metastatic breast cancer. And when she was on our unit, we had been giving her high-dose chemotherapy. She was on a continuous infusion of chemotherapy over 4 days. And during that time, Betsy continuously said to her clinicians, to her nurses, her doctors, her social workers, that she felt as though something was wrong while she was receiving the chemo, and that the side effects that she was having were not normal for her, and that she kept thinking that something was wrong. And those very talented, very well-intended clinicians responded to Betsy and said, no, we see this. We see these side effects with high-dose chemotherapy. They are normal. And Betsy continuously said, it is not normal for me. Well, she completed the chemotherapy, and she completed her bone marrow transplant. And on the day of discharge, after she had gone through her treatment, she had a sudden cardiac arrest and died. And we did not find out until a few months later that we had inadvertently given Betsy 4 times the amount of chemotherapy than was intended for her. So she was indeed correct. There was something wrong. And I can't help but think that if at that time we had understood what we understand today about patient and family-centered care and the importance of the voice of the patient and how it can directly impact an outcome, that her outcome would have been very different. Because after all, no one knows their body the way we do, and the way we each know our bodies. So that was what started my journey with patient and family-centered care. And that's when I realized, even though I thought that I was a nurse who was very patient and family-centered, I understood at that time that there was a lot more for me to learn and a lot more to understand about integrating the patient and family voice and their expertise, so to speak, about themselves into the care that we were delivering. And so flash forward a couple of years, or actually 8 years to be exact, my daughter Hannah, who is now 18 years old, 19 years ago when I was pregnant, early on in my pregnancy with Hannah, I was having some symptoms and went to my OB on a Friday morning, and he took a look at me and listened to what the symptoms were. And I kept saying, you know, something feels funny. I don't know what's going on here. And he did an ultrasound in his office, and he said, I'm so sorry to tell you this, but it looks as though you're going to have a miscarriage. And, you know, that will happen spontaneously. And if it doesn't happen over the weekend, we will go ahead and induce, you know, the process on Monday morning, and we'll make an appointment for you to come in if it doesn't happen over the weekend. And I left the office very upset, obviously, and still thinking that wasn't what was going on, but that something still wasn't right. Well, over the course of the weekend, I continued to have what seemed to be increasingly worse morning sickness. I became very sick and didn't understand what was going on, but I knew enough that I thought something's not right. And if I'm going to have a miscarriage, this doesn't seem to be going along with what's happening here. So that Monday morning rolled around and I had my appointment at 10 o'clock for the infusion, and it was 8 o'clock, and I decided to call a colleague of mine who was in his office, and I talked with her and I said, Judy, something's not right. Why am I so sick if this pregnancy isn't viable, and that, you know, I was in the beginning of a miscarriage? And she said, she goes, you're right, come on in and let's have you do an ultrasound in the radiology department, where they do this all of the time. And I went to the radiology department, they put me on, you know, hooked up the ultrasound, and it wasn't but a few seconds, and very clearly on the screen was a rapidly beating heartbeat. And at that time, I looked at it, and knowing, as a nurse and really knowing what I was seeing, I still asked, what is that? And they said, that's your baby's heartbeat, and it's beating very strongly, and it doesn't look like we see any issues with this pregnancy. And so, of course, at that moment, they canceled the appointment at 10 o'clock. But it was another example, I think, of the importance of the patient voice. And in this situation, obviously, I had a clinician who listened to my concerns and took action based on those concerns to validate or to at least explore what was really going on. And so the outcome, obviously, is this beautiful girl here on the screen. And so those are the stories that have fueled my passion over the years. And I tell you these stories because as we go through this presentation, I think it's important for all of us, in order to understand what patient and family-centered care is and why it's important, is that before we start a journey of education, it's important to connect individually with what it really means to you as an individual, and then to you as a leader. Because PFCC, as you know, those words, patient and family-centered care, are used all the time. They're used by everyone. They're used by clinicians, they're used by insurance companies, they're used by CMS, Joint Commission, and they all have slightly different definitions. So in order to really make sure that we're all on the same page, I share those stories, but also just want to share the definition as I go through these slides that I'm going to be using is a definition that has come out of the Institute for Patient and Family-Centered Care. And PFCC is an approach to the planning, delivery, and evaluation of healthcare that is grounded in mutually beneficial partnerships among healthcare providers, patients, and their families. And PFCC has 4 cornerstones. The first being dignity and respect, meaning that we listen to and honor patient-family perspective and choice. The second one, information sharing, meaning that we as clinicians communicate and share complete information to patients and families so that they can have the full and complete information so that they can fully participate as partners in care and in shared decision making. And then collaboration. Patients and families collaborate at all levels of care and at the organizational level and the delivery of care, and are viewed as full partners in the care team. So and then there's also participation, that patients and families can fully participate in care, and that was the third concept, I apologize, that around shared decision making. So those 4 concepts: dignity and respect, information sharing, participation, and collaboration. So that's what I mean when I'm talking about patient and family-centered care, and that's the definition we'll be using as we go forward. Okay, next slide. So first, as I said, first is the connection to why it's important to you as an individual and as a leader. And so What I'm going to talk about through this presentation is how, we've taken individual passion as leaders in my organization to transform a culture. And I say that knowing perfectly well that it really is transforming a culture because it's in process, it's not done. And I'll give you an overview of that journey at Beaumont Health. But before I start, for those of you who don't know about Beaumont Health is 5 years old, and it's a result of having 3 health systems merged together in 2014. Beaumont Health System Legacy, Botsford Health System, and Oakwood Health System. Those 3 organizations came together in 2014. It's actually 5 years this month, to form Michigan's largest health system. And we have a little over 38,000 employees, 5,000 doctors, and we have 8 acute care facilities that amount to approximately 3,500 inpatient beds, 145 outpatient centers, joint venture urgent care centers that are popping up as we speak all over Michigan. We also have a home health and hospice agency, along with 3 skilled nursing facilities. And just to give you an idea of, just in terms of the numbers of lives we touch, we have almost 18,000 births per year, along with 500,000 emergency center visits per year, and then 178,000 discharges. So this slide is really the phases that we have used and continue to move through and back and forth into to transform a culture. Next slide, please. So as we came together as Beaumont Health, we really, we had 3 distinctively different health systems and with their own different cultures. And we knew as we came together that we needed to have something that would engage the hearts and minds of our employees and our physicians. And we fundamentally believed that that was patient and family-centered care, that PFCC really would ground people back to what we all came in this to start, came in to healthcare to start with, and why we did that, and to really connect people back to that. And so we brought this idea to our board and did some education of our board about what patient and family-centered care is, what it would mean for our patients and families, our staff, our physicians. And they wholeheartedly sanctioned and really identified patient and family-centered care as a rallying call for all of our employees and physicians, so that it became our universal goal across our system. And, so on the slide, it says Moonshot 2022. And basically our goal that we identified was that we want to be the national leader for patient and family-centered care by 2022. And that was to fulfill our mission of delivering compassionate, extraordinary care every day. And that was what that was going to be our true north. And so we also called it our big, hairy, audacious goal, because this goal really, we wanted to inspire people and to also, set a goal that people could really get their hearts and minds around. And that seemed to do it. And people have embraced it passionately, and some more than others, to be very frank. And but more and more every day, thanks to the leaders across Beaumont Health and our site leaders and our system leaders who are very passionate about this, and our patient family advisors who continue to guide us in a very strong and impactful way. So next slide, please. So as I go through these, they're numbered, as you've noticed. These are not steps that are sequential, but they are things that we are doing and have done simultaneously, and each of them have their own evolution. So this structure, as an example, this is our structure as we have it today. and my guess is it'll even evolve even more as we go forward. But when we first started in 2015, we didn't have a structure at all. We really had folks, and thank goodness for them, wonderful leaders and staff across the system who were just passionate about patient and family-centered care, understood what it was, and really wanted to jump in and help to advance this. And so we started without a structure, but now we've evolved to the point where we do have a system steering committee that and then has each site, acute care site, and different, depending on what the services are, have different patient and family advisory programs. And we have site leads at the various sites to help lead efforts at their particular site, whether it's a hospital, a skilled nursing facility. We have leaders within our community partnership program who have been very strong and passionate about PFCC. So we have those leaders, and then they come together in a coordinating council regularly that feeds into and helps to guide bidirectionally with the system steering committee. And the system steering committee basically, with the site leads and our patient family advisors, and patient and family advisors are on all of these committees that you see here on this slide, create the quality standards to achieve consistency across the system. And then the sites operationalize the standards, but they also recruit and train patient family advisors, and they also create, and I'll talk about later in the presentation, the best practices are coming out directly from the site, and they influence the steering committee and the work of the rest of the system. Next slide, please. So this is our system leadership group that lead our efforts for patient and family-centered care. And from left to right, we have left is Lisa Muma, who is a registered nurse who works part-time with our system team. And then right next to her is Kelly Parent, who is our vice president for patient and family experience for the system. And she is our executive leader over patient and family-centered care. And then next to Kelly is Corey Jones, who is our director for patient and family experience. And then Melissa Norco, who provides administrative and program support for the team. And I wanted you to see these folks because Lisa was one of our first people who just jumped on board without even having a designated position, patient and family-centered care, to really help get things rolling. And a little over a year after we got started, we were able to hire Corey and Kelly. And what's unique about Corey and Kelly is that both of them started their careers in patient and family-centered care as patient and family advisors. And one thing that we know about PFCC is that, one of the foundational principles is about embedding the voice of patients and families in the decisions that are made by the organization. And so hiring both Kelly and Corey as patient family advisors, being a strong part in the beginning of their careers, really has been a game changer for us in embedding the patient and family voice into not only decision making, but into our administrative structure and our leadership. So, so these are the folks, all four of these ladies are the folks who work in partnership with patient and family advisors and with our wonderful site leads at each of our hospitals and other sites across the system. So it's this team is just the system team. The larger team is probably a team of about 15 or so when we put all of our leaders together for the entire system. Okay, next slide, please. So as we got started, there were a couple of things that we wanted to do, and not only putting together the steering committee and really introducing patient and family-centered care, we wanted to do some things that were visible and palpable so that people would say, okay, that sounds like a good goal, but now what? So we wanted to do some things that were visible and palpable so that people would really understand and say, okay, this is what patient and family-centered care is. So we immediately started to create policies and processes that that demonstrated what PFCC was. And the number one that we focused on was family presence and visitation. And when we talk about family presence, we basically did away with visiting hours at all of our hospitals and created a family presence policy, recognizing that families provide strength and support and knowledge when it comes to their loved ones in the hospital, in the clinic, wherever they may be. And so in order for them to do that and to really enhance the care, they have to be present and a part of the team. The other part of that policy was defining what family meant and what it is. And the definition of family is defined as by the patient. It is not the blood relative necessarily. And sometimes it's not the next of kin either. It's defined by the patient. And so those two were big changes that we started right out of the gate. The other was around how do we engage patients and families in their care. And there were two major initiatives. One of them, bedside shift report for nursing, was underway across the system, but there was a lot of variation and inconsistency. So we focused our efforts on having a common approach to bedside shift report and how we engage patients and families in that discussion so that they have an active voice in their care while hospitalized. And we're still working on that. That too has been a journey. Multidisciplinary bedside rounds. We've had two strong physician leaders in the system, one on a progressive unit, medical progressive unit, and then our ICUs at Beaumont Trenton, where we've had physician leaders who have spearheaded multidisciplinary bedside rounds with the inclusion of patients and families as part of that team. And then you see some of the others, end of life care, discharge planning and coordination of care, and then 24 hours post-discharge calls. Those were the 6 that we really focused our energy on initially as visible and palpable changes of PFCC. And that was as a result of feedback that we had gotten from patients and families, staff, physicians, that those were our areas of greatest opportunity. Next slide. So as we did that, we realized very quickly that as I said earlier, PFCC and patient and family-centered care was not a commonly understood term, that we all had different ideas of what it was and what it looked like. So we wanted to make sure that we, number one, increased awareness among our leaders, most importantly, because as these policies were rolling out, they impacted the front line and went forward, with that. And if our leaders didn't understand really what it meant, and didn't understand what supporting family presence meant, or how to do bedside shift report, it was going to be hard to really support staff in doing that. So we had leaders at the executive level, at the senior leadership level, who embarked on a process to reflect on their roles in patient and family-centered care. And we had a schedule that we took with the site-based leaders and system leaders, where we would go and around the clock on what we called road shows to share personal experience with patient family-centered care, to give out treats to people. We had pens and buttons and sticky notepads, and of course granola bars. We had to have food too, to really start the conversation with employees and physicians in their own areas, in their own space, to talk about what is patient and family-centered care, what does it mean to you, what does it mean to your department, but also, more importantly, to answer questions and speak to concerns about what their concerns were about patient and family-centered care. And of course, at that time, while we were rolling out the family presence policy, there was a lot of concern, and there were a lot of questions about that from our nursing staff. Next. So one thing that we've really understood is that if we were going to have authentic culture change, we realized that every policy, program, and process across Beaumont Health, we would have to be able to show that and reflect that we recognize our patients and families as partners in care and valued members of the healthcare team. And so it was really important, and Kelly and her team have been very deliberate in going from department to department to talk with them about how does patient and family-centered care apply to them. And you see the list here on the slide, that these are departments that it doesn't always come naturally to because they're not directly taking care of patients, but every single one of these departments, every corner of the organization has a connection into patient and family-centered care. So that dialogue has been really critical as we've gone forward. And so there was a very intentional, and continues to be a very intentional and deliberate focus on that. Next slide. I mentioned, about the leadership piece, and that leadership really needed to understand PFCC. So back in 2016, we started our process with, and you're going to see a theme as I go through this. It's education, education, education. The first big education event that we had was in 2016, where we had the Institute for Patient and Family-Centered Care come in and talk about the basics of PFCC. What is it? What does it look like? We had some wonderful speakers, including Bev Johnson from the Institute, wonderful patient family advisor speakers who told their stories and why PFCC was important, and just really focused on that education. We had some more education in 2017, but it was last year where we really, I think, really started to make some traction, or get some traction with our leadership, in assuring that leadership understood their roles and responsibilities as it pertained to supporting a culture of PFCC and being a patient and family-centered leader. And as you know, the tone starts with leadership. So leaders have to understand PFCC, or it's going to be really hard to have that transformation, because while a lot of this is exciting, some of it's scary and some of it's hard. And so to all be on the same page with that has been critical. And so again, another part of an evolving journey that is not a one and done education thing, but something that we will continue to focus on. But in November of last year, we had this conference called Imagine, and it was our leadership conference. And we focused on storytelling and connecting our leaders to why PFCC was important to them. So what I want to show you, and next slide, please, are two videos of two leaders that we were very intentional about choosing to speak at this conference. One, because they had very powerful stories and just do a beautiful job in telling about why PFCC is important to them, but also because of who they are. And I think sometimes when you have, one of them is our chief medical officer, and the other is an associate chief general counsel for risk management and claims. I think sometimes in our healthcare organizations, we have perceptions of different leaders, and most importantly, their roles and what they do, and whether or not they are connected to patient care and what that means for them, and for patients, and whether or not they really understand that. And so it was really important to be able to get leaders who could share their stories about PFCC to really bring it right to the sharp edge of care and care delivery. And so I'm going to have you listen to these, ask that you listen to these and watch these videos, and then I'll just say a few more words about them in a moment. The first one is Dave Wood, our Chief Medical Officer, and the second one is Sarah Kahn, who is our Associate Chief Counsel for Risk Management and Claims.
My dad was born 30 years to the day before me. Probably one of the reasons why I'm David Peter Wood Jr. Right around my age, we went out to dinner, and he said, Dave, you know, you have some papers to sign here. You know, these are power of attorney. This is my advance directive, all this kind of stuff. I go, what's going on? And he said, I just want to get this done. You're the only doctor in the family. And, you know, I just want to, you know, make it clear to you that you have this responsibility. So he said, just promise me that I won't wind up in some nursing home watching daytime TV, getting fed by a tube. I guess about 15 years later, I get a phone call from a hospital in Cape Cod. And they said, your dad is in 4-point restraints, out of his mind. Long story short, after about a month, a stroke, pulmonary embolism, he gets diagnosed with West Nile virus, encephalopathy, whole 9 yards. I see him every single day. And then I go visit him in the rehab center, and there he is, sitting in a wheelchair, strapped in, getting fed by a peg, watching daytime TV. Now, did anybody along the way ask me, what did your dad want? No. But did I verbalize it? No. It's this cascade. You don't realize until you're on the other side how this slope goes, and yeah, he'll get better, all this kind of stuff. About a week later, I get a phone call. It said, we just took your dad to the local hospital emergency room. Oh, no. I said, do not reset. And he goes, nope, our policy is, you know, if they get a fever over X, we take them to the emergency room. I go, but I signed these papers. No, in the fine print, it says that we have the right to be able to transfer that person. So it's about midnight. You get a phone call. Your dad's in the ICU and he's not doing well. I go, wait a minute. This is do not resuscitate. He goes, oh, that was at the nursing home, I guess, but you know, you didn't do it here at the hospital. I said, I'm not going to let this happen again. So I put on my clothes, put on a pair of scrubs, and I just walked right into the ICU. The monitor says my dad's blood pressure is 80/40, heart rate of 150, and they're jabbing him in his groin because they can't get IV access. Poke marks everywhere. I go, stop. And they go, who are you? I go, I'm his son. They go, well, we can't stop. We don't, you know, he's in the ICU. I go, stop right now. Give me your attending. Oh, the attending's not here. Just the residents. I go, get the attending in here. And I want you to stop right now. They go, well, we're gonna have to call security. I go call security. Go ahead. So isolated, right? Nobody supporting me, trying to do what I know my dad wanted me to do. And I did it. I was able to get into bed with him, and he died. But I reflect back on how much better that experience could have been for me and for him if someone would have said to me, what does he want? What do you want? What are your issues? What are your concerns? What is the never event that you want to happen? Because I would have told them, I don't want him going to the ICU. If we could develop a culture where it wasn't, you know, checking the box and filling out Epic, but instead saying, what does the patient want? What does the family want? I think that experience, which was horrible, as you can see, to this day, right? This is years later, could have been a pleasant, tragic but a better event.
I'm going to tell you a story about the way that a PFCC culture can pay dividends over the very long term. So the little face you see smiling down before you is me. It's 8-year-old me in 1979, looking through the business end of a striker frame. I was the proud new owner of a Harrington rod, which had been installed to address severe scoliosis wrought by the Marfan syndrome. But what is it about that picture that screams PFCC? And I would suggest that there's 2 features to it. The first is the vantage point from which it was taken. It was taken by my mother, who was lying on the floor underneath my striker frame. At this point, you should probably understand that I was hospitalized at Johns Hopkins for the entire month of June in 1979, and we lived here in southeastern Michigan. So my mother traveled with me, and she lived every moment of that admission in my room with me. She slept for 30 days on one of those reclining vinyl chairs. She showered in the bathroom of my hospital room. And when they made a Sarah sandwich out of those mattresses and flipped me over on my striker frame, she crawled onto the floor to talk to me. And while I would like to tell you that my mother was extraordinary, because of course she was, I don't actually think her behavior was all that unusual. And I think that point was made very clear today. I think many people, maybe most people, would behave similarly when given the opportunity to support a loved one facing similar challenges. The second thing about that picture that I think is interesting is that I'm smiling. It wasn't a big smile, it was just a little grin, a little Sarah-sized grin. But you need to understand that my scoliosis was so severe, I went into that surgery 5'1", and I came out 5'3". We had been planning for that event literally for years. I had spent 6 years in a Milwaukee brace. I had spent 2 years taking female growth hormones. A week before that surgery, they operated on my right knee to stop it from growing because it had outpaced lefty by 1.5 inches. I knew I had a long, hard road ahead of me. I knew the moment I got up off of that striker frame, they were going to cover me in plaster and keep me that way until Christmas. It was going to be a long, hot, stinky summer. And yet I was smiling. And I can tell you that I look back at that picture and I don't think pain or sadness or fear. I think victory and love. And I think the very simple reason for that is the next picture. And that's the lady standing next to me, who's my mom. She was there with me every minute of every day. And she made it very clear that we were in it together and we were going to win. And we did. So why am I telling you any of this? Why am I risking my professional career by crying in front of you? I'm telling you because I want to establish credibility. I want you to understand when we have an opportunity to work together in the days and weeks and months ahead, and we're staring down the downside of an adverse patient outcome. And I am insisting to you that we are going to resolve this in a way that fully honors PFCC. I want you to understand that I come from the most sincere place possible. It isn't that I've just thought about the problem and intellectually I've concluded that this is the right thing to do, although I have. It isn't that I feel morally compelled to take this path versus others, although I do. It isn't even that Susan Grant has articulated this as our moonshot, although of course she has. It's because a different Susan, the Susan in that picture, demonstrated to me in full living color all the dividends that a PFCC effort can pay.
Can you hear me?
Yes, hold on.
I'm going to go ahead and keep talking if that's okay while you get the screen back up.
That's great.
Okay, great. Thank you. So that was Dave Wood and Sarah Kahn, 2 of my favorite people, and how they articulate their stories around patient and family-centered care. And I probably don't need to tell you, I've watched those many, many times, and every single time I'm touched by them. and just recognize the impact of those stories in conveying two things. One, and probably most importantly, that patient and family-centered care, regardless of who you are, whether you're a chief medical officer, the general counsel, a staff nurse, an environmental services worker, someone in finance, it doesn't matter. They're all important. And we all experience patient and family-centered care and have an idea of what we want that experience to look like. And the second piece of that is that this is about partnership. That thing that we all want, it is about partnership, it is about inclusion, and it is about being heard and listened to as a patient or family member. And so, you know, I think that there is no better way to convey what patient and family-centered care is than through the personal use of stories, or the use of personal stories. So very quickly, a couple of other things that we have done and continue to do. We have developed an extensive and comprehensive education plan because, as I said earlier, PFCC education is not a one and done. It's not something you just give an orientation and then that's it. We have put into place orientation, you know, material for all of our new employees, regardless of their department, to hear about what patient and family-centered care is. And then we also have annual mandatory education along with our annual leader conference, which you saw a little clip of just now, site seminars. Kelly and her team have put into place a really wonderful bi-monthly forum to highlight best practices called One by One. These are fantastic, and I really want us to, you know, I'm hoping that we'll be even able to fuel these even more, because it's a way to share best practices, spread ideas, and create some consistency across the system. It's another way too to recognize the excellent work that is being done by different employees across the system, and to really validate and recognize and celebrate what they're doing. And yeah, just as an aside, the mandatory education is not only for staff, but for physicians. And we engaged our Physician Leadership Academy in creating the physician module for patient and family-centered care, so that it was something created by physicians for physicians. So, so that's another piece of this. But the other thing too, just as one more thing, kind of a silver lining, is that this forum and the work that continues to grow with PFCC and the number of individuals that continue to grow across the system around PFC is creating really a network of opportunities between and amongst the sites, but also a sense of community, I think, for many of the folks who are involved in it. And I know many of us are struggling with all of these mergers and, you know, big systems. How do you create that sense of community within your organization? So I think that's, you know, another, you know, silver lining and benefit from getting everybody on the same page with patient and family-centered care. Next slide, please. We'll just show this one really quickly. These are some of the pictures from our conferences. Oh, back to the last one, I'm sorry. Yeah, pictures from some of our other conferences. And I just want to highlight from these, they are multidisciplinary. We have physician leaders involved, many physicians leading these initiatives and partnering. We have a co-chair, a physician co-chair with Kelly for our Patient Experience Council that oversee a lot of this work. We have physicians co-leading the multidisciplinary rounding, our elderly or ACE units, they are also leading that. And of course, in all of these, patient and family advisors always as partners in the planning and serving as faculty for this training. Next slide. Just quickly, when I talked about raising awareness and the road shows, one of the takeaways from that was how important it was to have frontline discussions, listening sessions, and addressing challenges. Kelly and her team and the site leads and our committee structure have created ways to solicit feedback from our staff, from our patients and families regularly. But they're also conducting biannual site visits and meetings with managers. They do unit tours, they address current state, they talk about what's working, what's not. And those conversations at the sites allow for consultation, coaching through strategic goals and putting together action plans, and really assessing on a regular basis kind of what the needs are across the system. Next slide, please. So the other thing that has just been a wonderful gift through this process is, and a learning is, you know, really placing confidence and trusting your staff and physicians. You know, when you start bringing more and more people together and talking about this, at first it's a little scary, and you have patients and families in the room having these discussions. But the beautiful thing that comes out of it is these unbelievable ideas that people have as they start to talk and talk about how do we build these better partnerships? What are some of the things that you've always wanted to do that you think would really make sense and we haven't been able to do them? What are they? And so we created the Reach the Moon program, and that's what you see on the right. This is a grant program, an internal grant program that we've dedicated about $125,000 to every year, that support grants from the different sites, different departments across the system. Our first year, we had 181 teams submit applications, and we awarded 15 projects. Yes, I mean, that doesn't sound like a lot, but it was, and those 15 projects, we want people to be able to do what they're asking that they can do and have the funding to do them. So we are really seeing this be something that we're going to have to build on, because it has created great energy. It's a great way, again, to recognize people and the great work they're doing. But more importantly, it's a great way to generate ideas and things we've never thought of to advance the practice of patient and family-centered care. There was one other thing I was going to mention about these grants, and it just escaped me, but I'm sure I'll come back to it as we go forward. But this has really been a great initiative, and will continue as we go forward, and it's money well spent. Next slide. So you know that in healthcare, there's nothing that we do that we aren't asked for. What's the impact? Why does it make a difference, right? And so when we presented this, we had a lot of support, but there was also that expectation that we demonstrate and answer that question of, well, so what? You know, how is this making a difference? How do we know this change is an improvement? And so we have been on a process from day one in figuring out what are the measurements and metrics that we use to measure our progress in advancing patient and family-centered care practices and our culture. And, you know, we did call this the moonshot goal. So, of course, a lot of creative people immediately said, well, how do we know when we get to the moon, when we reach the moon? So, so you see on the bottom right of the slide, these, we started with, you know, our HCAP scores, but you know as well as I do, those don't, you know, and the comments, and those are very helpful, but it's not everything. And so we also know that, you know, our workforce is a big part of this. So we're looking at workforce, our staff engagement scores. Where do we have opportunities around that? And, you know, to be very frank and honest, the first year that we did this, we got a lot of feedback about people not really understanding what patient and family-centered care was. So that's when we really intensified the focus on putting together an education plan. We use our culture of safety scores. And then we're also, you know, really focused on, if we say we want to be a national leader, it's not about, you know, being number one. That is not what that's about. It's really about holding ourselves accountable and putting ourselves out there to say, here's what we're doing, here's what we're learning, and being held accountable for that by our patients, families, our community, and our colleagues across the country, to be challenged on that, and to say, okay, how are you doing this, or how are you doing that, to really keep us dedicated and focused on and committed to really figuring this out. Next slide. So one of the things that we did, I talked about HCAP scores. So when I was at University of Washington many years ago, Press Ganey worked with us in creating patient and family-centered questions, and they're custom questions for those of you who have Press Ganey as a vendor. We do right now. And so there are custom questions that are PFCC questions. You see them here on the slide. And we deliberately have implemented these. We are tying them into our performance metrics. We have them on our balanced scorecard so that we are holding ourselves accountable to our performance in these areas. And you notice number 1 is around presence. That question, degree to which your choices were respected to have family members, friends with you during your care, that directly goes to our family presence policy and how well we are doing with that. The second one around participation, degree to which you and your family were able to participate in decisions about your care. That again is about shared decision making and that core concept that I talked about in the beginning, one of the 4 core concepts of participation. How are we doing? And the initiatives we have in place for that, our bedside shift report and some focused initiatives around communication with doctors and nurses. The third one is really around teamwork and more specifically around coordination of care. How well staff work together to care for you. So what we've learned through our work around this data is that the patient's perception of how well you've worked for them and how well care was coordinated is a direct reflection on how well we have worked as a team. So those are the 3 that we are tracking. They are on our dashboard. Next slide. We've created this dashboard and this is a site view of the dashboard and it's very busy. I know I don't expect you to see all of it right now, but just a couple of takeaways from, we have one at the site and then at the system level that I'll show you in a second. But the dashboard, we started out with just counting how many patient family advisors we have. And we've evolved to deeper metrics and more meaningful metrics about not just how many we have, but how are they involved? What are they doing? How do they participate? What's the frequency? How many hours? How many have participated in orientation as an example? How many have participated in the interviewing process for new staff? Those sorts of things. It also includes, this dashboard also includes on the top where it says goals and Q1 milestones. Those are our annual operating goals that are from our strategic plan, and they're color coded and it tells you whether or not we're on track or not on track with those specific goals for the year. And then toward the middle right of the dashboard, we have patient satisfaction scores, but it's those 3 questions I just talked with you about. We decided that those are the ones we're going to focus on instead of focusing in on the many HCAPS questions. And then last but not least, and you can go to the system, the next slide. We are also tracking how many activities are we as an organization or individuals representing Beaumont participating in, whether it's presentations, expert panels, participating in think groups, et cetera, nationally. What are those? And that we've committed to doing that and supporting people in doing that, again, to advance the overall knowledge. And then publications, how many publications what are we writing about? How are we writing and getting this knowledge out there? And then research presentations. Those are some other, we've committed to do at least 2 a year that are IRB approved, whether it's participating with another organization or doing it ourselves. So those are some of the things that we're doing. And, like I said, these are all evolutionary and in nature, and we certainly aren't finished. And I expect if we talked a year from now, this will probably look different, as it should, because we're constantly learning. And then for the last slide, and you can't put all the learning in one slide, but very quickly, I've said it many times, making a connection to understanding PFCC through your personal stories. Educate yourself and build your expertise in your organization. Don't expect yourself to know everything. Bring in expertise, learn from your patients and families, and learn from your staff, and get as many people in the room as you can to have those conversations. commit to education, 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 and make it ongoing, not just for our frontline caregivers, but for the entire organization, including the board. Make it visible and hold yourselves accountable to it. Put it in your strategic goals and organizational priorities, report off to the board, and make your board expect that they're going to hear from you about it and hold you accountable to it as you move forward. And then that ongoing commitment to having patient and family advisors in all organizational work at all levels, or in organizational work at all levels, and then walk the talk as a leader, and challenge yourself and be open to challenge from patient family advisors and other colleagues. So Bev Johnson and I just published an article in Nurse Leader, in the August Nurse Leader, that has some more information about this, if that would be helpful to you as well. With that, I will stop and open it up for questions. We have time.
You know what, Susan, we went just a little bit over, but people are still on the line. There has been a number of questions chatted in. So if you can stay with us and answer.
Absolutely.
Perfect, thanks. So let's get started. That was just terrific. And we got so many comments about the very moving videos as well. So just wanted you to know that. And just I know these are tough questions to answer quickly, but Kate asked whether you could share a little bit about what you did regarding end of life and discharge planning and the post-discharge phone calls that were related to the aim of PFCC.
So end of life care, we actually have a lot of work underway where we've decided to focus on advanced care planning and engaging patients and families and clinicians in the conversations around advanced care planning. And instead of trying to take all of those questions at once, but for end of life, it is around respecting choices. We have implemented that program and have dedicated resources to that, and have engaged patient family advisors in that dialogue of how to go about that. The discharge planning and discharge calls, depending on our sites, and I wish we had time. I know some of our site leads are on the seminar right now, on the webinar. We have different sites working to address issues around care coordination by the use of discharge calls to make sure that, you know, we fill that gap from that we've heard from patients and families from the day of discharge to getting home, of not necessarily having the right information, complete information, the medications they need, and also to understand better why they don't have what they need, and is it something that we have missed, or what are the opportunities that we can facilitate to improve that transition process. I can, feel free to email me if you want, and I can share more.
Great, thanks. There's a question from Karen about staff accountability. So how, you know, can you just speak to a few ways that was addressed?
You know, one thing I've learned, because I've been doing this a long time, it doesn't help to push things on people when they may not feel as though they're open to it. I think it's a lot better to figure out ways to engage people in a positive way. And we, quite honestly, are focusing more on how do we recognize people and celebrate what they're doing and move it along that way. And also, how do we engage other staff who are doing great work to be, to share their story with other colleagues. And to bring people on board that way, if that makes sense.
Mm-hmm.
Now, for leaders, although for leaders, the accountability does come through performance. Those PFCC questions this is the first year that they've gone live. So the senior leaders are being held accountable for performance on those. And our goal is going forward that it'll be embedded in performance reviews at every level.
Great, thank you. Can you speak just a little bit more about the certification program you mentioned?
I'm sorry?
Can you speak a little bit more about the certification program?
Yes. We have not gone live with our certification program yet. It is under development, and we're very excited about it, hoping to go live with it perhaps next year. And, you know, when you look around out there, there isn't any, and it kind of goes back to my comment about everybody thinks PFCC, there's a different definition for everybody, depending on who you're talking with. So we really want to create a program that is a certification program that basically deems someone as having a full understanding of what patient and family-centered care is, and that they have the tools to help facilitate that in implementing it. And so, as I said, we are hoping to get that started next year. But there aren't any real programs out there now. I know that the Barrel Institute has a program for a certification program, but we really felt strongly that that the program we want to put together is it's a validation of skills and knowledge, but also more operational, if you will, so that people really can kind of go out there and get it done.
Terrific. People are very interested in your dashboard. Is there a way to share that template with us and that we can send out to the attendees?
Absolutely. And, you know, AHRQ, I believe, has it as well. They featured it, and we were very proud of this as a best practice. So, so yes, I can get that to you. Great.
Okay, so we have a few more. I'm going to answer some of these offline after the seminar, but I mean after the webinar, excuse me. There's a question about devoting resources to the individuals who may not practice PFCC, and so and maybe that's due to burnout or for other reasons, but you know, what resources are you using to in the annual performance reviews, for instance, or other ways that you're supporting those staff?
Supporting staff who do not support PFCC?
Yeah, and I know you mentioned that very early on, how some, you know, there's still work to do, but
yeah. I think it's engaging them. We are not doing that through the performance review process because I don't think this is something that I think at some point, you know, we're just not there right now to hold people accountable kind of from a discipline standpoint. Is, you know, we've just chosen not to go that route. What we have done and continue to do is when we have identified folks who are really struggling with it, to spend time, dedicate time with them to talk through their concerns. A lot of the time, their concerns are not they're things they've heard. They're not real things, and so I can think of a couple of my physician colleagues at first who, when we implemented the family presence policy, they had all kinds of ideas of what it meant, and they were not accurate. And so it's really about having the willingness to sit down with folks and have that discussion and talk through their concerns. And the nursing staff as well, you know, the family presence. And, you know, we've had to talk about that a lot, and we've engaged nurses and patients and families for that very real concern and issue of workplace violence. You know, people have been very worried about, oh my gosh, does PFCC mean that it's a free-for-all, that you let all kinds of people in and you have no say-so as to whether or not, you know, family members are in a room or not. And we've been very clear about that that's not what patient and family-centered care is, and that PFCC is about maintaining a safe environment for patients, families, staff, physicians, for all of us. And so what does it look like in that context? So so that's kind of how we're getting at that, is to really, I highlighted on a couple of our strategies, is to really be able to have that dialogue. And we've been doing this now since 2015. So, and we're still having conversations about that, but we also have 38,000 people. So, some days it feels like it's one person at a time, and other days it feels like, wow, that whole department's on board. So, it's I think that's just part of the journey.
Okay, I know that there are still some questions coming in. I'm going to respond to the questions, some of these questions post-webinar through emails. And I know that we didn't get to all of the questions, so we'll make sure that we review all of them and respond to you all. And I thank everyone for staying on the line, and I especially thank you, Susan. It's terrific. Someone chatted in. You're getting a lot of, you're very inspirational, we need to clone you kind of comments, and you've done a lot in 5 years. We agree at IPFCC in all of those. I'm going to hand it over to Annette. And she's just going to finish up.
Thank you, Marie, and thanks to everybody and all of your questions. I'm more than happy to answer questions, so just email me if I didn't get to your question.
Yeah, will do. Thank you.
All right, thank you, Susan, for that great presentation. And as I said in the chat, all of her contact information will be included with the email that also has the recording of this webinar and links to any of the resources that she may have mentioned. So now I'm just going to talk about PFCC Connect. If you want to continue the conversation, or if you want to get any ideas from everyone else in the field, it's a free online community that you can join and talk to other people around the country, around the world, and see what they're doing in their organizations to improve PFCC. So the link is on the screen, and you can definitely join if you would like. Thank you for joining us. We do have a webinar survey, and a link will be included into the post-webinar email as well. And if we could just have a few minutes of your time and give us some feedback on it. I know we had some technical difficulties, so thank you for bearing with us on that. And we hope that you can join us for another webinar soon. So yeah, thank you.